something.
So trauma, and we do see some blush here at the base of bulb, more on the left side. We see some stranding here. This is the arterial phase. Uh,
The
And there's
muscles
a
look a little bit
fracture
weird too,
nearby,
and there's a
right?
fracture on the
yeah,
left.
and I'm pulling the venous phase now. This increases, and I pull the delayed phase now, and but then there is no change of shape in particular. Yes, I do see some stranding. There is some fracture. This was probably called as active bleeding, but probably we disagreed. And although this is a trauma setting and it's like a tough call here, but I've seen many times that the bulb
Yep.
enhances asymmetrically. Like, sometimes it
Yep.
will be right, sometimes it will be left. And even with cavernosa, like sometimes the right enhances, sometimes the left. And it takes a little while for both sides to get to the symmetric enhancement. I don't know. What's your experience?
I agree with you.
For
Yeah,
both
I've
bulb
seen a
as
lot
well
of
as cavernosa.
Yeah, I've seen a lot of strange like blushes or enhancement in the cavernosa. So I've started to like
Mhm.
call it less because I think it's so vascular and yeah, different things are happening. It doesn't, I mean, maybe there's a little contusion or something there, but
Yeah.
if it's actually actively extravasating, they should see it like expanding even clinically for them, you know?
Yes, yes. And if it's in like and then the traumatic AV fistulas, like stuff that can happen later downstream, they're very symptomatic. They have priapism.
I agree.
Yeah, it is always a conundrum though, because we're not used to like, I don't know, what is the normal level of enhancement?
Yeah, there's not a lot of literature or we always hear about liver and like kidneys and prostate and whatever, but very little about prostate. I mean, penis.
Mm-hmm.
Yeah, I think I would mention it, describe it, and then just say follow clinically, and that we doubt that it's actual extrav, active extrav.
I think I like that, yeah.
Cool. Okay. So this person came with abdominal pain.
Some stranding around pancreas.
Yeah, good. So there's some straining like around the pancreas, kind of like there's some findings here as well.
Are those lymph nodes soft tissue anterior to the pancreas?
What is this?
Thrombus in the expansion and thrombosis of the SMV? No.
Yes, great pickup. So that's expanded thrombosed SMV. So it was like, is it pancreatitis? Is there SMV thrombus? And then one more finding, which was like kind of just stranding around the cecum. So they ended up getting a contrast enhanced CT.
So is it because of cecum there is phlebitis of SMV?
Great thought. So here's the portal vein. We can see that the portal vein and the SMV are thrombosed and they're stranding. And then going down to the cecum, it looks like this.
Oh, like a partly exophytic mass?
Okay, so that's the question. Is it an exophytic mass? Like, what is it? And what kind of colonic masses are exophytic?
Gist?
Yeah, but does
It
it
has
look like a
it
gist?
has fat. It has like fat in it.
Yeah.
There's like yeah.
Okay, I'm gonna give you one more follow-up.
If it was smaller, I would have thought of diverticulum, but because diverticulum also looks centrally like that.
Okay, here's
And
a couple of days later.
Oh,
It's
now there's
got
all
like
the
air in it, right?
infection.
And
Or yeah, something.
actually, this is the appendix right there going right into this. So this was actually a ruptured tip appendicitis. And this was the septic phlebitis of the SMV and portal vein.
Interesting. I just had a quick question here. I mean, although I did say phlebitis, but now now I'm having second thoughts because remember many weeks back, Tan had shown a case of sigmoid malignancy, which had gone preferentially to left lobe of liver because of SMV as well as the laminar flow in the portal vein.
Mhm.
So which means the right-sided stuff should go more to the right side, meaning SMV,
Correct.
could that be involved here? Maybe by retrograde extension.
I'm not exactly sure what you mean, but like, this is an inflammatory, like this is a tip appendicitis, like ruptured. And that's usually when we have a polyphlebitis, there is a GI tract source. And one other clue is that you can see like enhancement and inflammation around the vein here. And then it's spreading here. I thought that the SMV, like right-sided stuff, and SMV goes more towards the right lobe, and splenic vein goes more towards the left lobe. As
I
far as
think
like
you're
the
right.
laminar
Yeah,
flow.
yeah. I was confused in my head. Yeah, no, you're right. Yeah.
Okay.
Yeah.
Yeah. So anyway, it was just interesting because it was initially thought like, is this an exophytic mass? But that doesn't really make sense. Most colon cancers are mucosally based. They're not exophytic. Didn't really look like a gist. And then like, as Nelly pointed out, it had kind of like that fat attenuation in it. So like always, and then anytime right lower quadrant process, like always remember the appendix. So here's the appendix, and then like the tip is going right into this thing. So it was an inflammatory process mimicking a mass. They did a colonoscopy that was negative. They did see like a bump, like under the surface, kind of pushing like from outside, and that was like this inflammatory phlegmon. So, yeah.
So it must have happened. I mean, like it's there must have been some time between when
Yes.
the tip ruptured and when that happened.
Yes. So actually, the symptoms were like vague right lower quadrant pain for like 2 weeks. So
Okay,
I think
because
it was like a smoldering process, and then
yeah.
this polyphlebitis. Yeah. Yep. Okay, so this is like a 30-year-old female who had abdominal pain.
Some ovarian mass, and the IUD also is slipped, like it's
low. Yep, the
Yeah.
IUD is low. It should be within a centimeter of the fundal endometrium, and there is an ovarian mass. So what do you think about this ovarian mass? Do you think like any specific kinds or types you think about, or
The patient's not trying to get pregnant, right?
no?
That's usually bilateral.
What do you mean?
Like the ovarian hyperstimulation syndrome.
Oh, hyperstimulation. Yeah. And those are
Yeah.
usually like bigger follicles, but this is like a cystic and solid appearing thing. I do have an ultrasound. I'm just going to pause.
And it's like retropositioned. So this mass is a complicated like torused.
Okay, good thought. That could have caused the pain. Hold on. Okay, so here's an ultrasound. We can see the uterus endometrium is looking pretty normal. There's that low-lying IUD. And then this is the right ovary. So similar to the CT, it looks enlarged. So it's at almost 7 centimeters. It's got like cystic parts, it's got solid parts, it's enhancing, has vascularity. So it needs to come out. So anyway, this came out and it was a granulosa cell tumor. So I just wanted to briefly talk about ovarian tumors. About 70% are the epithelial tumors, most of which are serous and mucinous. Those tend to be cystic masses with varying degrees of septations and nodularity, and ranging from like the cystadenoma to cystadenocarcinoma. So often we call them like an epithelial neoplasm of low, moderate, or high malignant potential. Rare epithelial tumors include like Brenner, and then the endometrioid and clear cell tumors. Those are the ones that degenerate from an endometrioma. So those are all the epithelial tumors. That's 70%. 20% are germ cell tumors. That includes the dermoids, immature teratomas, and then yolk sac, choriocarcinoma, and mixed. Those are similar to like the testicular tumors. Those are all considered germ cell tumors. Most common are going to be the dermoids, and most of those are going to be benign and mature teratomas. And then 10% are the sex cord stromal tumors, and that's what this is. So sex cord stromal includes the fibroma, fibrothecoma. Those are the really T2 dark, like solid masses. The granulosa cell tumor, which is what this is, these produce estrogen and can lead to endometrial hyperplasia as well as malignancy. In this particular case, the endometrium looked fine. And then there's also the Sertoli-Leydig cell tumors, which are the androgen-producing tumors that can lead to virilization. And then both the granulosa cell and Sertoli-Leydig can have this kind of typical appearance where they're solid masses with cystic and hemorrhagic components. So anyway, this, in retrospect, I don't know if I would have called it, this has to come out, but it makes sense that this was a granulosa cell tumor. And yeah, that was it. These are low-grade malignancies. Most of them do not metastasize, only about 10% do. And the tumor markers that are really helpful for this are estrogen, as well as something called inhibin, especially Inhibin-B. So they'll use that to monitor these patients post-op in the long term to see if there's any recurrence. Yeah, so that was it. Any questions?
Cool. Yeah, that's a great case. Nowadays, they consider that most of the epithelial tumors are considered as secondary from fallopian tube.
Mm-hmm. And then also a lot of those like serous and mucinous ones, like, they're on the, the simpler they appear, they're more likely to be like the cystadenoma kind of benign stuff. Whereas the stick cell, like aggressive tumors that come from the fallopian tube, those are the ones that are like, the ones that are going to give you peritoneal disease and have a much higher mortality. So they're almost like two different beasts, like tumor biology wise.
Yeah. So I have this young man comes with right upper quadrant pain. So what do we see here?
Abscess, or there's a
Yeah.
It looks ill-defined, like with some cluster
fluidy,
line along the border, fluid containing with a rim of,
multifocal.
and then also edema around it.
Yeah.
And there's stuff on the left side, smaller versions.
And there's reactive right pleural effusion. So yeah, this is abscess in the right lobe. I want to show you coronal, which is more impressive.
I think I saw some thrombus in the right portal veins also.
Yes, that is correct. Look outside the liver for the etiology for this abscess.
There's
The right
fluid.
colon
Yeah.
looks edematous.
Exactly.
The appendix is a little thickened, but it doesn't look like that's the primary epicenter.
So yeah, cecal and ascending colon was thickened, and when we see liver abscess, particularly in the right lobe, and thickening of cecum, and
is it ischemic? Like it's very thickened
that's
and
a great thought. He's a
hypo-enhancing.
young patient, like early 20s. So when we see liver abscess in the right lobe, along with thickening of cecum and ascending colon, think of amoebic liver abscess, which it turned out to be.
It's funny. I was thinking that because it was like such a big solitary abscess in the right lobe, but I've like never seen them in this country. Is this from this country or where?
Yes.
Oh, wow.
Yeah.
Cool.
Although the patient is an immigrant.
Got it.
Yeah.
Okay. So this was a fairly young person who has a pancreatic cancer right there. And this was her initial stage in CT, which was read as, we have a pancreatic cancer and there were no metastases. This was DWI. So aside from the head mass, it was read as normal, which I agree with. So that was the original staging MR, which was done at day X. So then, for reasons that I have no explanation for, they did another MR, and it was done 2 weeks after the original one. And everything looked pretty much the same with one exception. At this point, I saw these things. Wait, shit. Sorry, the stupid PAX is insufferable. Okay. So now you see these things, right? They're tiny, and this was done at the same exact scanner. The parameters are pretty much the same. I carefully try to find these on the prior, and I just, maybe this was there, but majority of them were pretty much new. And you could only see them on diffusion. I'm not gonna go through other sequences, but I went very carefully and I did not see anything. And this ended up, so I read this as, new lesions, but, we only see them on diffusion, unclear whether, but because they develop so rapidly, probably not metastasis, probably infectious, inflammatory, or something like that. So eventually they actually did a wedge resection, and these are all metastases. So this was probably the most rapid development, and this is already 2 months later. You can see just the so many metastases, and this time you could actually see them on other sequences. If my PAX will comply. I'm sorry. Anyway, so at this point, I just froze. So at this point, we could see them on other sequences.
Wow.
Frozen. So we had like a long discussion whether or not you can trust the, because this was done on a very, very old scanner. That scanner is over 25 years old, and it's questionable whether it should be used in clinical practice. But it actually wasn't. The quality wasn't as bad. But the question was, can you compare and confidently say that they were definitely new, or just all technical? And suppose you can't, with this, not necessarily you could be 100% certain, but they appeared new, and they ended up being metastases. And this is the follow-up, 2 months follow-up exam. So you can see them. And they still kind of odd looking metastases, right? Because this is path proven adenocarcinoma. These are not neuroendocrine tumor metastases, but they're pretty hypervascular, most of them, which is really, really.
Those also could be shunts around them. Like look at that one in segment 8, like it looks to me like a hypoenhancing mass, but with like a shunt around it.
Right. So this a little bit more ring enhancing, but a lot of them are.
And also like shunts, because a lot of times those fibrotic pancreatic adenocarcinoma mets take out the little portal venules, and then the artery takes over. So like it's kind of classic to have like a shunt around it.
Right. So this is probably the worst possible like progression that I've seen.
Yeah.
Should I show another cute case?
Sure.
I have a companion case.
Okay, you show the companion case while I set off the next case.
Okay. My companion case is similar. A patient with pancreatic cancer. This is post-treatment. So we do MRIs on patients who are borderline and PET MRI because there's a paper published from the Rochester group showing that SUV change post-treatment, like adjuvant treatment, is a prognosticator of survival. So if the SUV goes down and there's a positive response, then they are less likely to recur and have overall better prognosis than masses that don't respond metabolically with neoadjuvant treatment. And so that's the PET part. The MRI part is for liver metastasis because that's the most sensitive modality to liver metastasis, and PET's not going to pick it up if it's small. And there's also background liver uptake. So that's why we combine it with MR. So MRI here on all the other sequences other than DWI, it's pretty underwhelming. But then on the DWI, kind of similar to Victoria's case, we see these like multifocal diffusion restriction. There, bilobar, right there. There's one there, one here in the posterior dome. And they restrict. This one here, for example, they all restrict. So, and you can only see it on the diffusion. And so the T2 looked fine. There's no enhancement, there's nothing. So these all turned out to be metastasis. So yeah.
Did they have it on the FDG?
No. So let me
Oh.
show you. Because they're small, right? They're not even showing up on the standard T2, like the post-contrast sequences. Like there's no way it's going to get picked up by FDG.
Really nice example.
Okay. So this is, I think I've shown a similar case years and years ago, but I love these cases. So, and I have like path correlates. So this is a good case, in my opinion. So should I just describe or?
I see steatosis.
Okay.
Mm.
Just routine steatosis.
No, there's like iron, like there's something funny about the out-of phase imaging.
There's something funny about out of phase images. Okay.
Is there superimposed iron? Do you have elastography?
There's no iron.
Yeah, the in phase doesn't look dark at all.
I'm sorry?
I said the in phase does not look dark.
Right. So, okay.
The India ink around the portal veins is sticking out to me.
Correct. Right. So there's India ink at the interface between liver and portal vein. And is there India ink at the interface of liver and fat?
No. So that means it's extremely steatotic.
Extremely steatotic. This is what it is on the post contrast CT. So this is like one of those, you know, I have maybe 10, 15 cases like this where steatosis is so bad that as far as MR is concerned, the liver begins to look like a glob of gross fat. So you have Indian cord effect at intersection of vessels and parenchyma, and not at the intersection of liver and fat. So the cool thing here is that, well, not cool, but the cool thing is that we have path, because this patient that had alcohol abuse disorder and went into acute severe liver failure, so much so that he required an urgent liver transplant. So we have an explant pathology on this. On pathology, 70% steatosis.
Wow.
Wow.
So this is what 70% steatosis looks like.
Incredible.
The liver is seen as a gross fat situation. I have another companion case of the dangers of excessive alcohol abuse. So this young man came into ED. His story is that he was in Spain having a good time with his friends. He self-reports a pint of tequila per day, although it wasn't not clear for how long this was going on. And then he came in with just vague abdominal pain that wasn't going away. So now you can see he has just a humongous perihepatic abscess with air and fluid levels, and just went down and into this mess right here. And it took us a while to figure out, but this whole thing is like whatever he has left of his appendix. Let's see if I can do this. Here you can see on coronal, all of this right there is like just a ruptured appendix with appendiculis.
So it's like a contiguous,
yeah,
rather than an intrahepatic.
Yeah, he basically had acute appendicitis and anesthetized anesthetize himself with enough alcohol to wait until it ruptured and formed this humongous abscess. And like if you think about it, normally people would get to ED way before they get to this point because it's just from pain. But he literally anesthetized, and like he gave himself enough alcohol that the pain was dulled, which is how they used to use they used to use alcohol like as an anesthetic even for amputations before actual anesthetics were invented. So he did it. So
Wow.
yeah.
And it's a good campaigning case. I showed one earlier, Victoria, of a ruptured appy too that caused a highly phlebitis of the portal vein.
Right. This is pretty. We don't have any prior, so I can't tell you what he looked like before, but this was pretty stark.
Yeah. Okay, this is a post-op. I'm going to show you the original soon, but first I want you to tell me what surgery the patient had, and focus on the pancreas area. So I'll point out a few things. We can see the pancreatic head.
The body, there's like a jejunum attached to it, like where they fillet the pancreatic duct for chronic pancreatitis.
Good thought. So that would be a Frey or Pusto procedure, but that's not what this is.
Looks like
The
it's going
pancreas
into the
here is actually
stomach.
connected to the stomach.
Oh.
So the body tail is connected to the stomach. The head is in normal position. The middle of the pancreas is missing.
Central pancreatectomy with anastomosis of the tail to the stomach.
Yes, exactly. So this was a central pancreatectomy, which is not something we do very common. Here you can even see that there's a little bit of ductal dilation of the body tail as it goes into the stomach. Not super common, and usually not something we do for adenocarcinoma because we like to have very good surgical margins. So it's something you do for more like either a benign lesion or a smaller lesion. So we were kind of wondering, like, why did they do the central pancreatectomy? And so we went and pulled up the original scan, and this was the lesion right there. So I want you to tell me what you think about it.
Cystic neuroendocrine.
Great thought. Cystic neuroendocrine is in the differential, so it looks solid and cystic.
Yeah.
And actually, this was a young male, so we're not really thinking mucinous because that's almost exclusively females, usually more in the body tail junction. So cystic neuroendocrine is a great thought. It also did have enhancement. Okay, yep. I'm going to, so Nelly said SPEN. Does it matter? Do you think it matters that it's a male? People like to say like SPENs are like young females.
No, we've seen it in men.
I've seen
Yeah.
them in older men.
Yeah. So I just want to debunk that myth because my residents will always be like, but it's not a young female. But anyway, yes. So this was a youngish male, but I've seen it in all different. So we can never, the only one that I really like to hang my hat on the gender is MCN. So anyway, we gave the differential of a SPEN versus a neuroendocrine tumor, and they resected it, and it was a SPEN. And I think it's a really nice, actually, kind of depiction of it, because these are all the little pseudopapillae. And as the SPEN grows larger, the pseudopapillae outgrow their blood supply and hemorrhage centrally, and that's what causes the actual cystic component. It's not from necrosis, and it's not from anything aggressive. So they treated this with a central pancreatectomy. It was a low-grade neoplasm, and the patient's doing great. That's the case.
So kind of a companion case, another youngish male. And we see, what do we see?
Can you scroll through more? So far, it looks ill-defined, like maybe an abscess. Yeah, it looks like an abscess.
Mm-hmm.
Almost
So
like a turquoise sign.
Mm-hmm.
Bit of the edge. So again, we're going to go look for a source like colon, appendix.
How are you able to say for sure that it's not a mass?
the borders are really ill-defined. Do you see like the serpiginous kind
Yeah.
of separations and clusters of like micro abscesses along the periphery that are coalescing more centrally? And then there's hyperemia around it. You see like there's more
Mhm.
enhancement around it. I mean, I guess
I think
there's
I
mass
think
like that, but I really favors an abscess.
I agree. I would really favor an abscess bit because I've seen awful cancers mimic that. I would, I mean, this would need to be drained anyway, but I would make sure that they follow it until it's getting smaller stuff. Because I have collection of cases where it's mimicking just like this, looks like this. And it's cancer.
It also, I think the appendix was also a little suspect.
Yeah.
What can you do with the appendix?
Yeah, I was going to the appendix only.
Yeah, so it looks like that little mildly dilated inflammatory change around it.
Yes.
And then actually like, yeah, some straining going up the mesentery. It's pretty impressive that that abscess is from that.
Yeah,
But
that's exactly what I was thinking.
Yeah, even we were very surprised because appendicular changes are not as impressive, but that was the only source we could find.
And it's on the right side of the liver.
Exactly.
Which
cool. Okay, I have my next case up. What do you guys think?
retroperitoneal.
Yes. Okay, so we have a heterogeneously enhancing retroperitoneal mass.
It's very hyper, like whatever portion is enhancing is very much hyper around the IVC, like a paraganglioma.
Yeah.
Great thought. Exactly. So we thought paraganglioma. We gave a differential, and I'll tell you, in the end, it wasn't a paraganglioma, but we gave a few other things. So we said also, like, the pancreas is here. It's a little atrophic. This lesion is interfacing with the pancreatic head here. So we also gave, and like that, it's displaced over here. So we also said neuroendocrine and acinar cell. Acinar cell can be aggressive, but it can be very heterogeneous like this.
Did he have high lipase?
There was no high lipase. Nope. That's a great thought. So acinar cells can cause hyperlipasemia. We did not think it was really an IVC leiomyosarcoma, even though it is interfacing with the IVC. Just the bulk of it. I mean, even though a lot of them are exophytic, it just seemed like it was growing not kind of longitudinally along the IVC plane, but like more kind of horizontally here. Anyway, they biopsied it, and this was a well-differentiated neuroendocrine tumor thought to be arising from the pancreatic head.
Wow.
Yeah.
Great call. I wanted to say neuroendocrine, but I didn't. That pancreatic head finding I didn't make.
Yeah.
So that was a great call.
And I think in retrospect, like, I think it's a good, I don't know, paraganglioma versus neuroendocrine, I think are the dominant things. Would you say in retrospect, like, I don't know, it's like, okay, maybe a paraganglioma wouldn't have been as lobulated, but I don't know. I think we can just still give the differential. Yeah, so that was that. Recording. Okay, patient's having abdominal pain. You can see that there's some biliary dilation. And then an abrupt termination right here. I think that's like the low cystic duct. What do you think? I can show you some other sequences, but.
Infiltrative process, almost entire body, and like entire pancreas.
Yes, so infiltrative process involving the entire pancreas.
You can see a little bit of ducts here and there.
Yes.
That's that river sign.
The what?
The Guadiana River sign. So it's a river in Spain that goes above and below the water and the land. And it's what Ivan Pedrosa calls like this sclerosing ductitis of the pancreas in what condition?
IgG4.
Yeah, or just more generally autoimmune pancreatitis, right? Okay, and then I'm going to show you their pancreas a month ago was basically normal. So interestingly, this patient is on Keytruda or pembrolizumab for a parotid gland tumor, and this was thought to be Keytruda-induced autoimmune pancreatitis. So drug-induced autoimmune pancreatitis, which is one of the complications that you can see with Keytruda.
Wow.
And just treated with steroids, yeah. They did an ERCP, put in a stent, did brushings, everything was negative. IgG4 level was also negative, which is also common. So it's not an IgG4 autoimmune pancreatitis, but it is a different version of autoimmune pancreatitis from immunotherapy.
Yeah. There are three types of autoimmune pancreatitis. Type 1 is the classic, what we call as IgG4. Type 2 is again autoimmune, but that's not IgG4. That's more type 1, which is IgG4 mediated, is more common in elderly males. Like most of these conditions we see more in females, but that, like PSC, is seen in elderly males. Type 2 is seen in young adults and has association with ulcerative colitis, and type 3 is immune checkpoint inhibitor mediated, which this is. And all of these three types can be diffuse like this or can be focal. And on imaging, we can't differentiate one versus other. Thank you.
Yes,
I
exactly. And-
what do you
Oh, no.
see like you know, with the IgG we see a systemic extrapancreatic findings. What else do you see with Keytruda immune checkpoint inhibitor induced autoimmune pancreatitis?
Yeah, no, that's a very good point here. For IgG4, if you find other systemic findings, it points more towards IgG4. Most common site is pancreas, and pancreas is often associated with distal CVD, like thickening. And if you look outside the abdomen, pancreas also has like around 70% times inclusion affection of the salivary glands, submandibular. So if we see any other systemic manifestations like affection of the CBD or kidneys or periaortic soft tissue or the submandibular glands, or interestingly, some soft tissue around T8, T9 vertebral body, that's pretty specific on the right side, all these findings go more for type 1, which is IgG4 mediated.
Awesome. And then also, Nelly, to talk about the Keytruda, it can just be isolated to the pancreas. It doesn't have those classic additional organs like Yashant just described. However, it's not just pancreatitis that it can cause. It can also cause autoimmune hepatitis, autoimmune encephalitis. So there are different, like it's not necessarily multi-system, but it can affect different organs.
And I've also seen sclerosing cholangitis from immune checkpoint inhibitor, like cholangiopathy.
Yeah. I mean, I think it's kind of like in that way, it's an immune related thing. So it can affect any way that like, your immune system can, but it just doesn't have those classic multi-system.
Or concurrent multi-system findings.
Yeah.
This is an interesting case. The patient had just a multiple giant hemangiomas that I believe were known. You can see that, right? So this patient already came with diagnosis to us, so I don't know, but obviously it wasn't missed. But you can see here that, you can see that there's also biliary dilatation, right? And if you pay attention carefully, right, so it's very easy to kind of dismiss everything and just say, oh, there's probably some buildup from all these big hemangiomas. But if you pay very careful attention, you see that there's another lesion here, which is what obstructs the bile ducts. And it's kind of like, you can see it has that evil gray of tumor, which, by the way, Aarti, that term, which I know you coined, like it's like a thing now. Even like incoming first years know it.
I don't know if I coined it, but it's a good term.
I mean, every time I hear people say it, I'm like, yeah, Aarti.
This looks like a hilar cholangio to me.
It is.
Yeah, it's sort of on the border of like a mass forming cholangio.
Right. So I think it's a large duct cholangio. Well, it is large duct cholangio. And the reason why I really like this case, because no mistake was made and the diagnosis was made here, but you can see how easy it would have been to miss it here, because I think once we have so many big lesions, the brain sort of shuts off and kind of like, oh, everything is the same and all the problems that come with it are from this. But you can see that there's this subtle tumor, which would have been very obvious if the patient had no other lesions. It is much, much more harder to detect because we're distracted by everything else here. And you can actually see here, right there, you can see on CT a little bit better than the MR. You can see it's involving the common hepatic duct. It has a infiltrative component, and then it has mass forming component, which is typical of large duct intrahepatic cholangio. It has both components. So it's just a reminder to be careful in cases with severe pathology. Sometimes, let's say like when patients have a lot of hemangiomas, a lot of cysts usually, and I'm looking for something small, I actually will say that multiplicity, given multiplicity of findings, detection of small blah, blah, blah may be difficult. But you can see here, right, like it would have been a relatively easy miss to do, but thankfully it wasn't missed, it was called appropriately, and patient is
And probably like basically unresectable because the right side is isolated to the secondary radicals, and then the left side is not much of a future liver remnant because it's like got a huge hemangioma in it.
I think they're planning to do the left, extending left.
Oh, wow.
Yeah.
Because those right radicals don't even all come together.
They'll just do that's their plan to cut and do like multiple anastomosis, because that's the only
Yeah. Because normally they need like the
so they're trying to be as aggressive as possible. She's not an old woman, so that's the plan. At least I know the plan is to take out the left and somehow have her stay with right.
So multiple of those bile ducts to a jejunal loop.
Yeah. Which
Got
is
it.
not ideal, but better than to not resect, I guess.
1 minute. Okay. What do you think about the pancreas? First of all, most
It's
of it is
severely
gone.
atrophic, and there's like multifocal hypodense masses in the head and then in the body.
Yes. But if you just saw this part, what would you
Calcifications.
Lipomatosis, fatty atrophy.
Yes, and fatty atrophy is often seen in
Cystic
Cystic
fibrosis.
fibrosis.
Yes. So anyway, this is a case of cystic fibrosis, so fatty atrophy, but also, the parts of the parenchyma that are left have some signs of chronic pancreatitis because of those dysfunctional enzymes that are working. And then these are basically like dilated ducts because of like blocked with mucin. So anyway, these are also things that you can frequently see in cystic fibrosis, which is like pancreatic cystosis, which is basically obstruction of those dilated ducts. Here we can see some with the debris and a lot of the fatty atrophy of the pancreas itself. So
there are other findings of cystic fibrosis like GB stones as well as fatty liver.
yes, and actually, yeah. So yeah, she had definitely had a fatty liver, and yeah. And the other big thing you taught me about actually was the micro gallbladder.
Yes.
Just from the inspissated enzymes and stuff. So
yeah. And just because of the same inspissated secretions, they have larger dimension of appendix. Like, for regular population, we say 6 or 7 millimeter is the cutoff. There's no cutoff for cystic fibrosis patient, but they can have really like big appendix like 1 to 1.5 centimeter and still not appendicitis.
oh wow, just from like the mucoid.
Yeah, because the mucus just sits there and it just keeps distending it.
Cool.
So, like cystic fibrosis patient do not have cholecystitis because the gallbladder anyways is small. They usually do not have appendicitis because of the secretions. The lumen as well as the bore of appendix is anyways larger. So you need a much larger impact or much larger pathology to obstruct it and cause that symptom. And if their pancreas is not subjected to chronic and acute pancreatitis and it's already atrophic with fat, they will not have pancreatitis. So they're in a way saved from all these three processes.
Oh, that's really interesting. Okay, thank you.
Thanks
Thank you.
all.
Yeah.
Bye, everyone.